Niniola Williams is the managing director of Dr. Ameyo Stella Adadevoh Health Trust. I mean, that name rings a bell, especially when we think of Ebola, the Ebola epidemic. A public health nonprofit developing and equipping health ambassadors and hygiene champions to build a strong, accessible, and resilient health system that is prepared to handle emergencies, provide quality care, and save lives. Prior to leading DRASA, Niniola worked with Management Sciences for Health, MSH, a global health organization operating in over 50 countries with a focus on priority health issues such as HIV and AIDS, tuberculosis, and malaria. Before MSH, Niniola worked with a brand agency while also serving on the core team of Ameyo Soy, a Kenyan nonprofit focused on water, sanitation, and hygiene, that is WASH projects, as well as medical outreach programs. Niniola holds a BA in Cognitive Science, Neuroscience from the University of Pennsylvania and is certified in Social Sector Management, Infection Prevention and Control, that is IPC, and Antimicrobial Resistance, AMR. She is a member of the Most Influential People of African Descent, class of 2018, Advanced Media 100 Most Influential Young Nigerians 2018 honoree, TEDx speaker, and an Acumen West African Fellow speaker, and an Acumen West African Fellow. Ladies and gentlemen, please join me as I welcome our next speaker, Niniola Williams. A round of applause for her, please. Thank you.
Good afternoon, ladies and gentlemen. I'm happy to be here today. I'd like to start by standing on existing protocol and thanking the organizers for the opportunity to contribute to this conference. I was here last year. I think I've spoken at this conference every year since 2017 when it was taking place in Ghana. So I'm happy to be here again. And as was mentioned, I'll be speaking on the topic of infection prevention and control, which is one area of biosecurity and public health that's very close to my heart. So without further ado, I'll get started. Today, I'll be talking about what is infection prevention and control. I'll be talking about infection prevention and control and its role during a pandemic. I'll also speak about the opportunities and barriers we have here in Nigeria and across the continent regarding infection prevention and control, and then I'll talk about the way forward. So I want to start by asking a question: what is infection prevention and control? I know many of us may have heard of it and we may understand it, but for me, the easiest way to explain it is to tell a story, because I think that we can all relate to stories more than numbers or statistics. For me, on a personal note, infection prevention and control is the area that's one of the technical areas of DRASA, the health trust NGO that I run. And the reason is because during the Ebola crisis in 2014 here in Nigeria, my aunt, Dr. Ameyo Stella Adadevoh, was the doctor that diagnosed the Ebola patient and later died. And she and 3 of her colleagues in the hospital contracted the virus from the patient. And that spread of a virus within a health facility is what happens when you don't have infection prevention and control. So the 4 of them that acquired the infection from the patients suffered from a lack of IPC. So I'm going to speak a bit more about that today. But I want to introduce you to someone called Joshua. Now, this is not a Nigerian story, but I know we can all relate. Joshua was a 27-year-old man who had an accident where he fractured his femur and his skull. He was in the ICU for 5 weeks, but he recovered, and he was on the road to recovery. He was doing so well, in fact, that his parents were told he would be going home very soon. And he was admitted to a rehabilitation facility to begin learning how to rewalk and get back to normal life activities. 6 days into his rehabilitation, he began feeling sick. He was nauseous, and he had a high fever, a temperature of 103 degrees. Enterobacter, which is the name of a bacteria, was found in his system, specifically in his cerebral spine fluid. And later that night, when they got the diagnosis, his parents were called and they were told that, unfortunately, Joshua had suddenly coded, he had stopped breathing, and in fact, he was on a ventilator in a coma. So from being rehabilitated to go home, he was now suddenly in a coma. The quote from his mother that I want to make sure we all understand, she said, "On October 22nd, our son died, but not from his original injuries. Joshua died unnecessarily from a hospital-acquired infection, bacteria, that caused pressure in his brain, led to sepsis, and finally took over and ended his life." I'm sure many of us can relate to this story. We may know people who have been admitted in hospital for something very simple. While they were there, they suddenly got sick, either got very sick and stayed in the hospital for an extended period of time, or in some cases, maybe they didn't even come out of the hospital. Many times, these things can be prevented. This particular bacteria that you see on the screen is well known as a healthcare-acquired infection. It's not something people get in the community, going to school, going to work. It's something they get in the hospital environment. So IPC is all about preventing this from happening. It's a science, but it's also a practice. And it's about creating a safe environment for people to get the health care they need when they're sick, to ensure that the health care we're delivering is quality. But it requires expertise. Now, what IPC is not, it's not just about training. It goes way beyond that. It's not just about putting on PPE, wearing gloves, wearing masks, and all of those things. And it's also not a vertical program that we should implement at a particular point in time when we feel there's an issue. When we feel, oh, there's an outbreak, let's quickly come and use IPC to stop it. By then, it's already too late because whatever pathogen has already started spreading. So IPC is something that is a health system strengthening approach that should be embedded in our health system at all times. It should be routine practice, not an emergency response. Now, in 2019, Nigeria participated in the Joint External Evaluation, and I want to just point out, it's an evaluation tool that was used for countries around the world to see what are the weaknesses in your health system. And for us in 2019, you can see under point 3.3, infection prevention and control, we scored 1. It's red because it means that we were in trouble at that point. But what I want to talk about now is the fact that since then, IPC in Nigeria has improved, specifically here in Lagos State, and I'll give some examples. And that is largely because of the COVID-19 pandemic. So that takes me to the next part of this session, which is about IPC in a pandemic. I'm not going to stand and talk about all the things we've done in the last year and a half. That was one of the things I spoke about last year at this conference, but I'm going to talk more about why IPC played such a big role in the pandemic and why it continues to do so. In the beginning, COVID-19 was a new virus, novel. We didn't know anything about it, really. We did not have any particular treatments, and we certainly didn't have vaccines. And so the only defense that we had in the very beginning of the pandemic was IPC, infection prevention and control. Now, of course, we know that in the minds of people in the communities, IPC was not their defense. They were relying on other things: gin, agbo, dongoyaro, other local concoctions and remedies. People were relying on things like ginger, steaming. They believed that this is what was going to stop the spread of the pandemic. But in truth, IPC was the only true defense we had because we had nothing else to lean on and nothing else to break the chain of transmission. So that is why everybody became an IPC practitioner. Whether you knew you were doing it or not, you were doing it. And what do I mean by that? Well, you can see in these pictures what IPC looks like when it's done outside of a hospital, outside of a health facility. Wearing masks, keeping your hands clean and safe, social distancing. In the bottom right corner, you'll see people social distancing outside a pharmacy in Oyo State. In the top right corner, you'll see students spaced out wearing masks in a classroom. In the bottom right corner, you'll see Veronica buckets, those closed buckets with taps, which became very popular and still are during the pandemic. These are all means of breaking the chain of transmission and stopping a pathogen from moving from one person to another. And these strategies work for more than just COVID-19. They work for many of the pathogens that we find in Nigeria and across the continent. So before COVID-19 actually came, we had already started working with Lagos State Ministry of Health. Specifically, my NGO was prepared. We knew it would come. It was just a matter of time. And we started training and doing assessments at the mainland hospital in Yaba, the former infectious disease hospital, as well as the Lagos State University Teaching Hospital's Infectious Disease Unit, because we figured those are the two places that would first be burdened once we had our first case of COVID-19. And this training and preparedness was looking at how well are these staff able to practice infection prevention and control at this point in time, January 2020, before we had our first case. We were also looking at how prepared the environment was, an assessment of the physical infrastructure they had to be able to accept such patients and treat them successfully. And then in February and March, just a month later, we had our first case. So this picture was taken after one of our EOC meetings, that's Emergency Operations Center meetings. You can see the Honorable Commissioner for Health in the middle. And the man whose face is covered, for privacy reasons, is our index case, the first patient we had here in Nigeria who was confirmed to have COVID-19. You'll see me on the left side, or on your screen, it's on the right side, members of WHO, NCDC, and other partners who are there, working hard from the very beginning of the pandemic and still are till today. So what did the Emergency Operations Center do? Now, we were a member of the Infection Prevention and Control pillar, because like I said, that's one of our technical areas as an organization. And we did a lot of training, yes, but we did a lot of site assessments as well, monitoring and evaluation. I think this slide, okay, monitoring and evaluation. Tracking healthcare worker infections was another big part of what we did, ensuring that we were able to see how many health workers were contracting the virus while working in the health facilities, because for us, that would signify a breach or lack of infection prevention and control. And then also looking at guidelines and SOPs, developing tools that people could use to deal with this new virus that we had never seen before. So we did a lot of training, like I said, of both clinical health personnel and non-clinical. So everybody from the people working in labs, collecting samples, to the ambulance drivers, to the cleaners, the porters, the hygienists, the people that manage the waste coming out of the isolation centers, and then of course the doctors, nurses, and clinical staff involved in direct patient care. So this is some pictures of some of the people we've trained since the pandemic has started, and you can see that our goal is to make these people champions of IPC. And the training I'm talking about, I'll talk more about it later, it's not just a short-term training. It's a long process to learn how to do this. And so we're training them and sending them out. So you can see that they're part of a network called the Orange Network. The Orange Network is a network of health facilities in the 6 geopolitical regions of Nigeria. You can see here, not only do they work in the facilities, but we also send them out. They go to schools and educate people in their communities on what to do and what not to do. And they go on radio, they become really our experts, and we cannot be everywhere doing everything, so these guys are our ambassadors going out and doing the work. But we don't just focus on health workers, because that's just one segment of the population. We have done trainings and built the capacity of many different kinds of people, from the informal drug sellers, that's the PPMVs, proprietary and patent medicine vendors, to teachers and school administrators, to religious leaders, community leaders. We've even been to prisons and engaged with inmates and people that run prisons. We've trained flight crew during the pandemic when domestic airlines were getting ready to restart operations. We trained all the domestic airlines and their staff on how to reopen safely, how to conduct their flights safely. That was in partnership with the Infection Control Africa Network. And also corporate staff, when people are reopening their offices and trying to find ways to do things safely. In this new normal that we have, we were there to assist. We also did assessments of COVID-19 centers, and these pictures are from Lagos State specifically, where when Lagos State was building and establishing isolation centers, there's a lot of concern around infection prevention and control. The way a building is structured, the way it is constructed, can either make the spread of pathogens easier, or it can stop the spread of pathogens. So the construction process was something that we did in terms of looking at the infection prevention and control implications of the way structures were established, both for isolation centers and treatment facilities, as well as quarantine sites where people were held as they were entering Lagos from other countries. Now, we did track health worker infections and deaths in Lagos State, but I'm not presenting that data today. I wanted us to look at the global view. WHO last week released this report that said that their mid-range estimation is that 115,500 health workers have died from January 2020 to May this year. Now, that's a significant number when you think of countries like Nigeria, where we already have a shortage of health personnel. We really can't afford to be losing more personnel to preventable things like infections that are spreading in the facilities where they are working. So what are the opportunities and barriers to IPC? Why is it not done? What can we do to make it possible, and all of that? I'll talk about this briefly just to give us an idea of where we can go looking forward. So the COVID-19 pandemic has given us an opportunity. We know there's been a lot of loss, there's been a lot of suffering, there's been a lot of difficulty. However, from an infection prevention and control point of view, IPC programs have now become mainstream. It's something that people understand. People understand that if you wear a mask, it means that the droplets can't come out of an infected person. If you wear your own mask, someone else's droplets can't enter your nose and your mouth. Those are scientific principles that have become simple and everyday things that we do in terms of infection prevention and control. And so IPC is now more relevant than ever because COVID is not gone, it's not going, it's with us. And we know there will be more. There will be another thing that comes, which may be a virus we know, or it may be something we will have to learn and give it a name and start figuring out how to stop it from spreading. But either way, there are high levels of awareness of infection prevention and control across stakeholder groups in every country as we speak. And people understand why we need IPC. So that is an opportunity. Now, another opportunity is that we don't actually have IPC practitioners. And what do I mean by that? I don't just mean somebody that attended a 3-hour training and says they got a certificate. I'm talking about people who are professionals, have studied the microbiology and the science of this field, and are able to do this as a profession, not just as a thing that they got a certificate for during COVID-19. In Nigeria, as we speak, we don't have a career path for this cadre of health workers. Other countries do, but we do not yet have one. And it's a very unique field, and it requires people to develop a wide variety of skills, working with a multidisciplinary team. It's not limited to clinical health workers. The example I like to give is we forget sometimes the importance of the non-clinical staff in our health facilities. And I'm going to highlight the cleaners. Many times we just don't include cleaners and hygienists in our training and our capacity building. We just think that their cadre doesn't need anything. Isn't it just to clean? What's the big deal? But we have seen in facilities where a cleaner has taken supplies and materials they use in an isolation center or with an infectious patient. Imagine a mop or a rag being used to clean that area, and then taking that same mop and rag and using it to clean a neonatal ICU, for example, where you have very small babies who are very vulnerable to all kinds of infections. So without training, without empowering them, they can't help us in this problem. They can only be part of the challenges that we're facing. So really, it's not just about doctors and nurses, it's about everybody that works in the health facility playing a role together. Now, we don't have IPC programs in Nigeria for the most part. The places where we have programs, they're weak and they're not really well functioning. But one of the things that is an opportunity is the fact that we don't have to wait till everything is lined up and perfect. WHO has this graphic that I took from one of their guidelines, which shows you that it's a process. There are some minimum requirements you must have to have IPC, but you don't have to wait till you have the full range of things on ground to be able to say you're doing IPC. And so it's important for us to look at starting with the low-hanging fruit, starting from where we are today, and managing with the resources we have to make something happen. Another thing I want to add is that infection prevention and control is a huge part of patient safety. The story I read in the beginning is a patient safety story where you have a patient who died from something that could have been prevented, and simply because of the facility he was in. Infection prevention and control, as Dr. Alimi said earlier during her presentation on what the Africa CDC has done, is also an issue of occupational health. As a health worker, I'm employed to work in a hospital. I show up to work every day. I shouldn't have to then be burdened with potentially contracting a deadly virus at work, carrying it home to my family, infecting other people, and possibly dying myself. So it's a big contributor to health worker safety. And finally, it helps us with the antimicrobial resistance problem that we have all over the world, which right now WHO is saying is a silent pandemic and is the next big thing we're going to have to face because we're really not paying attention to it the way we should. And I won't talk much about that. Dr. Alimi did a great job of giving us an overview there. So what are the facilitators? Well, I'm happy to say that Nigeria has done well. We have a national IPC policy, which was done in 2013. I'm sure many of us have not seen this document before. It's domiciled in the Federal Ministry of Health. However, the good news is that it has been reviewed, and it's now going to be a fresh policy that will come out, we're hoping, before the end of this year. We've been part of the team that's been reviewing this policy, engaging with stakeholders, and getting ready to launch it. So that's something that Nigeria has done very well with. In addition, as Dr. Alimi said, the Africa CDC has established a legal framework that provides a backbone for this policy, that enforces the policy. And these are the kind of things that need to now be domiciled at the national level and at the state level. We also have a national curriculum, a standardized curriculum to train IPC practitioners, and it's a diploma course, and it actually exists right here in the University of Lagos College of Medicine. We were one of the partners in developing this and implementing this. So far this year, we've gone through 2 cohorts of students who have gone through the course. The advanced level, which is the full diploma, takes 12 months. So this is more like a master's course. There's research involved, field work, practical simulations. It's a full diploma. And the idea is that we're training people and educating them and certifying them to be practitioners. But at the same time, we also do short courses for frontline personnel who just need quick skills to know what to do at work. And then this is something I'm very excited about. We were one of the contributors to the National IPC Manual, which was just launched earlier this month. Some of us may have seen it by the Nigeria Center for Disease Control. It's the first time Nigeria has ever had anything like this, and Nigeria is one of the few countries in Africa to have an infection prevention and control manual. So this is something that is charting the course for what IPC is going to look like across the country. And the best news is that last week, we conducted a workshop with the Lagos State Ministry of Health to begin the process of domiciling this national manual within the states. So Lagos State is one of only 2 states, Enugu State being the second, that is already taking the national guidance and making it our own, adapting it, customizing it so that we can use it to improve the quality of care we are giving patients across the states. So we had a workshop with led by Dr. Folarin Apawe, who is the Infection Prevention and Control Lead for COVID-19, Dr. Folashade Ogunshola, who is the lead of the diploma course at the University of Lagos, myself, members of the Ministry of Health, representatives of NCDC, and others. So this is a very exciting process, being that Lagos is, again, a forerunner and leading this process for other states and showing people how these things can be done. Another thing that facilitates the process of having infection prevention and control programs is core components. And these are 8 things that WHO has said you must have if you want to be successful. These are evidence-based. These are tested, tried, and true. So we have a roadmap. We don't have to try and reinvent the wheel or try and figure out how to do it. It's already laid out. And so what are those core components? I'll just quickly run through them. The first thing is you need a program, which means you need a unit, department, committee. You need a structure around what is IPC going to look like. You also need guidelines, which, like I said, Lagos State has already started domesticating for the states. You need to have education and training. And you need to be doing surveillance, which means you need to be looking for these incidents and tracking them. That patient story I gave in the beginning is not a Nigerian story because we just don't have those Nigerian stories. There's no repository you can go to go and see what has happened or what is happening in our health facilities regarding the spread of infections. So we need to improve our surveillance to be able to track and have the data we need to make the decisions, policy decisions, resource allocation decisions, and all of that. Then we have the multimodal strategies, which I'll speak about next. Monitoring, audit, and feedback is a key part of any change you want to make. If you don't monitor it, if you don't give feedback to the people involved, there's no way you can say you're being successful in what you're doing. Then the workload, staffing, and bed occupancy, number 7, is a big deal. In Nigeria, we generally overwork our health workers. We don't have enough of them, which is the main reason why. And then oftentimes our bed occupancy is a challenge in our health facilities. And then number 8 is what I spoke about earlier, the physical environment, the infrastructure, the building, the pipes, the lighting, everything that makes up a health facility, the brick and mortar, is actually an IPC consideration, and it's something we need to think about. And I just want to highlight core component 5 here because I think it's the easiest one to walk through in the limited time I have today. Core component 5 says that you must go through these 5 steps for every change you want to make. And I want to give the example of me going into a facility and wanting to improve the way health workers are cleaning their hands. Maybe I observe that they're moving from one patient to another without washing their hands, without changing their gloves, which we know is one way that pathogens spread from patient to patient. The first thing I'm going to do is I'm going to build it, which means I'm going to build something for them to change. So maybe they're moving from patient to patient because they don't have hand wash stations. They don't have alcohol-based sanitizer available. So I will provide those things. That's building it. The second thing I'll do is I'll teach it, because it's not enough to just put a hand wash basin there and assume somebody is going to use it. I need to teach them how to use it, when to use it, the methodology to use to wash their hands and clean their hands. After I've built it and I've taught them how to use it, I have to check in and make sure they're doing it and give them feedback and monitor how they're doing it. And when I've done that, I also need to do number 4, which is selling it, which means I need to help them remember. I can put up posters about washing hands, cleaning hands. I can put up job aids and SOPs that will show them exactly step by step what they need to do. Once I've built it, I've given them the materials and infrastructure they need. I've taught them. I've given them feedback and monitored them. I've given them a way to remind themselves of what to do when I'm not there. Then I can reach the last step, which is step 5, which is when I have a culture change, when I can step away and there can be accountability within that system for those things to continue beyond my external influence. So this is just, again, to emphasize that the roadmap of what we need to do has already been provided. It's just for us to implement it. Part of the other facilitators includes establishing IPC committees and teams at the state level, at the LGA level, and at the facility level. Very important. If nobody's in charge, it's nobody's job. It will never get done. And we should have these people as our champions at each level. It requires collaboration because, like I said, IPC is linked to so many things. It's linked to the occupational health, the safety of the health workers. It's linked to the safety of the patients. It's linked to our quality assurance programs. In many of our hospitals, we have quality assurance programs, but part of delivering quality healthcare is ensuring that you're not spreading infection while delivering that healthcare. So we can partner with the quality assurance teams. We can partner with the occupational health teams. We can partner with the existing systems that we have on ground. And of course, antimicrobial stewardship is a big thing in our health facilities. I know many facilities in Lagos State have antimicrobial stewardship committees to stop the spread of resistant infections and pathogens, and that's very much tied to infection prevention and control. Another thing is having access to a community, because these things are not easy. I might make it sound easy when I'm saying just wash your hands, just do this, but in reality, it's very difficult to make these changes in the health sector that we have. So having a community of people that can work together, share knowledge, exchange resources is very important. And share innovations, because one thing that COVID-19 taught us, which I think Titi had mentioned in her session, was we have to be innovative. We have to think outside of the box. The pandemic forced us to be very creative, and we should continue in that creativity as we try and solve some of these health sector problems. Having mentorship and partnerships is also another way to facilitate it. Now, what I want to mention is that infection prevention and control is not about pointing fingers. You, health worker A, you didn't wash your hands. Your patient is now sick and dying because you've given them an infection. That's not what IPC is about. It's about ensuring that there's accountability and giving people roles and responsibilities, but you can't expect them to do what they don't know. People are not taught IPC when they're in nursing school, when they're in medical school, when they're in pharmacy school. So you can't expect them to know these things. We have to empower them to be able to do the right thing. And so it's not about pointing fingers, it's more about hand-holding and working together to get these things done. So let's talk about the barriers, because that's where we really have challenges. There are lots of barriers. Some of them we may have to break down, some of them we can go over or under them, but the point is that they exist and we need to know what they are. Most times it's because we don't have support from the top down. leadership and management may not understand the importance of IPC, mostly because we don't see it as an economic issue. But in other countries, they have so much data, they can actually quantify the cost of not having good IPC. The cost on the health sector, the cost on the patients. And so it's important that we look at the commitment and advocacy that we're doing to get IPC embedded in our health system as a preparedness measure against whatever pathogen may be spreading next. We also don't have the resources we need. I don't need to go on about that. Financial, human resource, and others. And at the end of the day, IPC is about behavior change. How do we change what is already happening on ground? And we need a new mindset in order to be able to do this. So just to wrap up, the way forward, we need to be proactive. That's why this conference exists, talking about what we expect to happen in the future and how we can mitigate it, how we can plan against it. So thank you very much.
Thank you very much, Niniola Williams. Every time I think of Dr. Stella Adadevoh,